everyone, my name is Minjung Cho. I'm one of the social media section editors of the Archives of Plastic Surgery. I'm excited to introduce APS Hot Off the Press. 2 times a month, we'll be hosting Hot Off the Press with one of the recently published APS authors and 2 panelists. You have a special opportunity to hear directly from the authors and join an insightful discussion between panelists. You can also leave your thoughts as a comment for further discussion.
Hello, everyone. Welcome to Hot Off the Press. My name is Rocio Perez, one of the social media editors for the Archives of Plastic Surgery. Today, the article is Lymphological Liposculpture for Secondary Lymphedema After Breast Reconstruction, and Long-Term Results After 15 Years. Today, we have Dr. Manuel Corneli from Institution of Research in Germany, author of this amazing article. And also we have panelists, Dr. So from Austria, and 2 of our ambassadors, Dr. Alejandro Zapata for Pablo Tobón Hospital, Medellin, Colombia, and Dr. Mario Cherubino for Cleveland Clinic, Abu Dhabi. Okay, let's start with a little introduction from you, Dr. Corneli, and your presentation.
Thank you very much for inviting me to give you a presentation here in a few minutes. This was an extraordinary thing to do this work, because I wanted to know how were the results after our surgery in the secondary lymphedemas for arms, and so I'm glad to kind of present these results nowadays. As you all know, the incidence of secondary lymphedema is enormous. We have 100,000 tumors a year in Germany with mammocarcinoma, uterine carcinoma, and others. And of these patients, around about 30% will develop a lymphedema. The question is always well known, but just for 4 statements here again, lymphedema is one of the most important long-term side effects of breast cancer, and I just will talk on breast cancer at the moment. The meta-analysis show around about 20% rate, so even every 5th patient which was treated with secondary with breast cancer will at the end have a lymphedema, so it's necessary that we have a good treatment for these. We have no good studies which can show us that doing lymph drainage, post-surgical or post-surgical could prevent the secondary lymphedema. And the 4th statement might be that lymphedema, if it happens, is not a catastrophe, but it has to be adequately treated. That's exactly the question. What is the clinical signs we see? We see a volume increase, and we see as well the side difference and the weight. So two points we have to do the treatment on, which is possible at the moment. We have a congestive therapy, which is conservatively. We can do, for example, lymph node anastomosis, and we can do sections, which are prescribed since 1997, I think, was brought up first. But which goals can we show? We can do the conservative treatment and find at the end compression garment for the ladies for the rest of their life, even they have to go on with the treatment for the rest of their life. And when we have the anastomosis, we can see that we have a good lymphatic flow with quite good result as well in the volumes. And when we harvest the tissue, we are looking for other results, which I would like to show you here in this presentation. So we have 2 goals. The one is to reduce the frequency of the complex digestive therapy, if possible, to make it completely unnecessary. That would be the aim. And the second is to make a circumferential adjustment of the affected limb to the opposite side. This was my idea to show can we evaluate the imbalance and bring out to both sides arms again. Tissue removing lymph vessel sparing surgery procedure. I called it lymphological liposculpture because it's not a cosmetic treatment, it's a treatment of a lymphological disease. And it is always, when I do it, it's done in 2 steps. The first is to remove the subcutaneous matrix. And you see, I do not write it's fatty tissue. I just say it's a subcutaneous matrix with the system of PLA under Tumescent local anesthesia and additional sedation. And the second is that we have a special post-surgical follow-up program for the following 6 months. I will go on this later on. So just for quick remarking, the anesthesia, Tumescent anesthesia, then you see the swelling of the area, and then necessarily we have a long-term preparation phase. We take 1.5 hours. The liquid, the tumescent liquid, goes into the fatty tissue and prepares the area we want to resect. And afterwards, this is the resection area. And as I want to show you here, you see we have to go even in this area. It's the volar side of the forearm. We have to do it there, or if we do it in the legs, we have to go down to the toes with a 5 mm cannula. The follow-up treatment, first of all, compression. Surely you see the first day after surgery is going further on with combination of a special treatment of lymph drainage and compression stockings. We like to do it over 5 weeks, starting with a 60 minutes drainage every day and a 24-hour compression. If necessary, additional bandaging, quite seldom necessary. And the week 4, 3, and 4, we go on to reduce the lymph drainage. We call it accented lymph drainage to just 3 times the week. When we reduce the compression to 12 hours and not to 24. And so we go on with reducing. And at the end, we want that in the week 24, we should have finished all this so that we are at the end 6 months after the surgery. This was the idea. Here are the simple results from surgery in the arms and the legs. And now let's have a look on the study population. We took 65 ladies, 24 arms and 41 legs in a period from 2005 to 2020. And we wanted to answer how many patients could the volume be reduced or at least adjusted. So when we took the consultations after 15 years and measured it with the machine, I'm sorry for that we had not the 65, but the 42 patients in these studies because of the others that didn't want to come to our office. We had telephone calls and could discuss how they feel and how is the life quality. But the measurements we just could do it in this part of the population. You see, the trick was that we said the other side, the healthy arm, we take it at 100% line, which is here, and we want to know how good can we reach and meet on this line. And all of these points is in the patient, and you see we were not really happy. This here are really nice results directly on the same side, so that we can say these are arms which have a look as it is on the healthy side. But what is with this rest? So the question was, this plus of lateral compensation of the extremity is due to the skin thickness. We shorten it with SFT. Alone, this is typical for the disease. So we cannot reduce the skin fold thickness itself by suction, because we can just suck the matrix beneath. So if you want to share a better result, you have to oversuck these patients. We did not. And just to give you an expression what this it really means with the skin fold. In normal persons, in healthy arms, only the skin thickness makes 3% of the volume. It accounts up to 3% of the volume. If you have a mild lymphedema or a moderate or a severe lymphedema, you see that the thickness goes up to nearby 17%. Just because of the skin we cannot change while we are doing the surgery. It's necessary to know these when you try to give an answer. Why are all these spots from the patients not on the 100% line? They are lying in midst of this 70% area. So this is the best we could treat. For us, this shows that we could take away the stuff under the skin, but we cannot treat the skin itself. So surely a resection of subcutaneous tissue reduces lymphedema volume significantly better than conservative therapy, but it doesn't change anything in the skin thickness. And this increase of the skin thickness had nothing to do with the increase of the volume of the lymph. You have to remember this, please. The second question was, how many patients could we reduce the frequency of the conservative therapy or even make it completely unnecessary. So have a look on this. This is pre-surgical from all the patients, and the most of them had the therapy twice a week. And when we do the surgery, we have better results. Even these nearby 60% do not go on with more conservative therapy. But I would like to show this in a better graph, like you see it in here. These are the 65 patients we had contact with. 5 of them had no improvement, but 60 of them, you see 92% had a good improvement. And from these, 38 patients did not use longer conservative therapy for the rest of their life since the 15 years. And these 22 patients reduced it down to twice the month or once a month, something like this, less than 20%. So at the end, we had 2 aims we wanted to reach. One was to reduce the frequency of the decostic therapy. If possible, we take it completely unnecessary. And the second was to reduce the circumference of the arms to bring it to the condition of the healthy arm, which was the aim we were looking for. I think for the future, we need to combine the methods. As we know from John Zui is on the panel, he had good results. He and other guys have good results with the LWA, with the LVA, and has improvement of 43% of the circumferential. But I think the combination of doing the suction, which is in this area here, and the LVA may give us better results. So thank you very much for this quick presentation.
Thank you so much, Dr. Cornely, for your presentation. I think this is amazing work, and actually a really good one, because you're following this patient for 15 years. And actually in Korea right now, I'm Dr. J.P. Hong Fellow, and I've been looking a lot of lymphedema cases. And so I noticed that it's different kind of approach of treatments in lymphedema. Not different, it's the same goal, but maybe combination of different procedures to get that goal. So your work is really good, but I wanted to ask you, do you have other group of patients that only perform LVA and you can compare with your results of this work?
Not for me. I'm just doing the resections. I'm a liposuction guy. We did this since more than 25 years in lipedema with good results, and since 2005, identically in breast cancer patients. So we have no, I cannot give any commands on the LVA with my patients, but I know there are guys on the plenum who can tell them something on this.
Yes, and another question before we pass the post to Dr. Zapata. Do you use any technology to do liposuction in these patients that maybe help you to get better goals, like laser, Renuvion, or any other?
Question from me? I'm sorry.
Yes, for you.
Sorry again.
Yes, no, don't worry. Do you use any type of technology to assist your liposuction, like maybe Baser or Renuvion or any other?
No. We just take the typical client solution. We add an hyaluronidase, which is an enzyme, to bring it in a better preparation, the stuff into the cells. That's it. Because we believe that it's not fat, or we know it's not fatty tissue, it's as well proteoglycans. And I want to smash these. So I give hyaluronidase into the liquid of Klein. That's all. And then we take the PLA machinery and do a suction, as everybody knows. We have no other instruments, don't use laser or something like this. No.
Interesting. Hyaluronidase, then you add to your solution. I was thinking that too, because it's fibrosis, and when you got fibrosis, normally you use that type of enzymes to get this look. That's really smart. Okay.
That's exactly the point. We published this 5 years ago, I think, in SOAT, which is what's the question? how does hyaluronidase work on polyglucan. And we did this in a new publication. If you like, I can send you this. And we
Yes.
wanted to know if any results in there. But just because we are unless it's an idea. It is not proven scientific. We have no lab or something like this. We just know that we can take this stuff, and when you do the suction without this stuff, it's really hard to suck it. And if you prepare it in this way, you feel it's much more smoother to suck. And we believe that this is a good way. And even it doesn't hurt anything in the patient. We are going up to 5,000 units per liter. And so I wrote this in the paper as well. I have a look in the paper.
Perfect. And in the rehabilitation, you do the massage. Do you use any like machine to get like faster recovery, like ultrasound or?
No, we just take the first day when they stay for 1 night in the hospital, and then we take a 30 minutes mechanical with a machine, with intermittent pneumatic system. But from the next day, we begin always do it with the manual drainage, because it's a start in the center, and then we do accented. We call it accentuate manual drainage, because we do the accent on the on this area which was surgical. We did the surgery, so we treat exactly the arm, and the rest of the body always the same. That's the idea at the moment. Even we have nowhere on the world any scientific findings on how manual drainage works. But doing it just from the practical way, we know we have good results in promoting the healing. This was the idea. And the second idea was that we promote this new situation in the arm. The limbs are not in good shape, and we take away all the tissue beneath the skin and the muscle. It's taken anything away between the tissue and the muscle, down to the fascia. So at the end, this space has to be new drainaged, and I call it it's a training for the lymph. We can talk on this maybe. Even we have no idea how they are damaged by a sclerosis, because we do not know it. We just know all the vessels in secondary lymphedema are okay, because it was just a nodectomy typically, and not damage in the vessel area. So we stay with normal lymph drainage and normal compression.
Of course. Thank you so much. I will definitely add more to my comment. First, I want to hear Dr. Saul. Do you like to make any question or comment to Dr. Connolly?
Don, we can't hear you.
Can you hear me now?
Yeah. Yes.
Oh. Thank you so much for organizing this meeting and this video call, and thank you for the invitation. It's my honor to be part of this discussion panel, and I would like to congratulate Professor Connolly to his excellent result that he has done in the last 15 years, and that he published a long-term result, which is very important for lymphedema surgery, to see what kind of method, what kind of surgery is feasible and also long-term lasting, sustainable for the patient. And you mentioned shortly about your liposuction, Professor Connolly, and we also know from Professor Brorson that he has a dry technique, but what you use is the wet technique.
Yeah.
So, and your wet technique, as I can recapture, if I recapture, is that after your liposuction, you emphasize you do not need any compression therapy.
Yes.
That means patients are free. That means they are actually healed from lymphedema.
Yeah.
Could you maybe emphasize what's the pathomechanism compared to the dry technique and your wet technique that you have carried out in the last 15 years?
I could just try to answer. When I give you the story, when I'm working on liposuction of lymphedema since 1997, and then there was a lady. She came with a lymphedema and a secondary lymphedema, both in the same lady. And I struggled what to do with her. I knew how to remove the lipedema. I've got lots of experience in these questions, but I was not really sure belonging to the secondary lipedema of the arm. So I called Rüdiger Baumeister in Munich. He gave a telephone call and said, Rüdiger, what do you think? He said, okay, there's a guy called Brozon. He does this since 1997, and he does it in a dry manner. I said, why does he do it in a dry manner? The technique of wet suction was described in the 70s by Klein and so on, and it's not necessary to do it in a dry manner. So I had a conference with Archon Brozon. I read his papers, and we called on this, and he said, yeah, we are doing this way because of, and I don't want to go on this now. But I didn't feel comfortable with it because they, as you know, give a blood Löfgen manchet on the arm, and then they take away the fatty tissue. I would be in fear that we damage anything in there. And the second is that Rosen up to now says, when we finish the job, the patients have to go on with the compression therapy. And then I said, this doesn't make any sense. Because if I want to do it correctly, I will smaller the arm, and I want to take away the conservative treatment. That was the idea. So we did it in this one lady. And I told her before, I do not know if your arm will be, the secondary lipedema arm will be so good like just with the lipedema. I can tell you what will happen after the lipedema. We'll see. We have a look on the secondary arm. And so we tried it. She said, okay, do it. And then we found that even she did not need a compression after 6 months. So we had the first idea that it might work this way. And then we went on, and since 2005, we did this, what I showed you today. But when you ask me what happens under the skin when they do this surgery, I just can't tell you. What we do is to rebalance the in and out of the lymph, for example, it might be this. And we saw that it's necessary to do the post-surgical treatment. We had one patient, she didn't do this because she didn't want to do. She came to the surgery, then we went home and saw her a year later, and then she had big problems. Said, what did you do? She said, I went home, and then I went to holidays and did anything afterwards. So we had the worst case in her. We did the section again, and then it was okay. So just from my point of doing it quite often in the year, I would recommend that it's necessary to give around about 6 weeks, 6 months post-surgical treatment with conservative therapy, as I told you, and then try to reduce the compression and the lymph drainage. My aim is to bring them 20 of a measurement from 20% before the surgery. If we can aim, they do need nothing, it's great. It's the best way you can do. But these question John points directly out that we have to think on what is our aim when we start the surgery. Is it just to remove tissue and bring the patient in the situation to go on with stocking? I would say no, that doesn't make any sense. What we need is to give them a better life quality without any more conservative treatment. And this was what I could show here. In the combination with Hyaluronidase, complete sucking, preparation phase, and 6 months post-surgical treatment.
That's a great result. Thank you, Professor Connelly, for your comments and your answers. And I think we hope that in the future, all surgical therapy can be like this, that patients are healed from lymphedema. So thank you so much.
Thank you.
Thank you, Dr. So. And now, Dr. Alejandro Zapata, can you please share a comment or you have any question for Dr. Connelly?
Well, for me, it's a great honor to know you first. I mean, in video, not in person, sorry. But I'm a huge fan of you. I know you are a lipo guy, like you said, but I admire so much your work, because for me, now we just create our lymphatic center here in Medellin, Colombia. And for us, it's very common to find patients with lipedema and lymphedema. And we have maybe very soon we're gonna hear about our casuistic, our method, but I have many questions. I mean, for me, it's not everything discovery now. For me, it's a huge surprise when you get into the OR. And for me, it's very difficult to select who is the better patient and who becomes the, who will be the great candidate for perform LBAs or perform LBAs plus liposuction, or if you're gonna use technology, which one could be better use ultrasound for the skin retraction. And just call me crazy, but I believe sometimes that you can do both of them, or maybe the whole package. Okay, and we're never gonna know, because I think it's not correct to compare if you're gonna do this to all these patients and you're gonna just perform LBAs for everyone. So for me, I just want to hear your opinion of my job, because I just select my patient for liposuction when they have lymphedema, and you can feel like very fibrotic tissue is very tough, but you cannot feel the liquid. I mean, you cannot feel the lympha. So when I feel the lympha and I see that they're gonna improve with LBAs, and then if they going to, like, I call it like tough phases, like tough part of the lymphedema, you can perform liposuction. And for me, your technique is the better way to do it, because I believe in wet. I believe that you need to wait. You need to wait. Is no, or because at the beginning I start to do it and I have to perform transfusion in patients, because the bleeding is a huge problem for me, and I have 3 patients with like enormous transfusion after surgery. So what do you think about that approach?
So thank you for your questions. First of all, when you do liposuction or the resection of the subcutaneous tissue in secondary lymphedema, but as well in lipedema, and if you need a transfusion afterwards, this is a really disaster. So if you damage a vein, okay, but then it's like you do surgery in veins, you give a compression, that's it. But if you need a transfusion, and I know this from Borzen, he published it, that's too much. It is unnecessary. We have a soft tissue, we can bring in there a liquid, we can wait. That's a problem, I know, sometimes, due to the hospital telling quicker, but necessarily you have to prepare, you have to do a preparation of the stuff you will suck afterwards, and you will see that sucking it, it's like taking a jelly out of something. It's very easy. The time you wait, you are quicker in doing the sucking. The second question was one which I'm always discussing with John as well. I would call it triage the patient. Which is the best patient for which method? First of all, we did stage 1, 2, and 3 lymphedemas in this paper. So, as you know, due to the stage, the skin fold thickness is arising, because the first change in the skin you will see in lymphology, you will see in the skin. The skin fold is arising, even in stage 1. So remember that you do not change anything in the thickness of the skin. That's necessary to know. We have no chance at the moment to do something. I do not really believe these ultrasonic devices. We wait what they can show it on scientific base, not only on the selling base. I would like to see really histology, and I would see before and after, and then this suction, and then we go on with histology and so on. So again, to my beginning first arguments, I think it's necessary that when you do surgery, when you treat patients by surgery, you really have to know what could be the aim. And when the aim is bringing you a better condition of quality of life, because I take away the drainage necessary and the compression necessary and the movement and the weight of the arm and all these other things, so you know where you want to go. The third question was, which could be the best method? Is it the LVA? Is it the node transplantation? Is it the suction? I see it in an easy way. Doing a suction on one arm takes me around about half an hour after the waiting time, maybe an hour, maybe normally half an hour. That's it done. But all of you who are doing the LVAs know you will have to take it up to 4 hours. And when you do the nodes as well, it's the same problem. So even you do the nodes and do plus sucking, which is quite often, you are erasing the time. I think it's easier to do it this way. Do a suction completely, do the post-surgical training for 6 months, and have a look on the results. And if the result is good and you do not need more conservative treatment, then stop anything. And if you see, okay, it's not the best I like, I would like to have it better, then you can go on to think on, I do an LVA now on the second step. This is my idea, but John may be another idea. So this could be a way to do a triage from the clinical point of view. This could be an idea at the moment. But last sentence, as I know, worldwide, there are no programs on these questions. We did not have a protocol on this question. It could be necessary to have such a protocol in good studies so that we can give you this answer in 15 years from now again and say, okay, this lady is 35 years old, she's secondary lymphedema, breast cancer, stage 2, the best for her is that or that. This could be the approach I would like to have. Thank you for your questions.
Thank you, Professor. I really appreciate. And just one comment. What do you think when you find that the patient just keep your program after 6 months, and sometimes I don't know if it happened to you. Maybe you have like very long-term follow-up. So for you will be like, what happened? Because call me crazy, but sometimes I perform like ultrasound liposuction in one side of the leg, and in other I don't perform ultrasound at all. Call me crazy, but after 1 year, the follow-up, I can see no difference. I mean, it's like, I don't know how to say it properly, and just forgive me, but like, I'm not saying what's going on, but I believe the technique that you perform the liposuction should be high quality, even if you use like ultrasound, laser, whatever. Yeah. I mean, the technique for the liposuction could be perfect, and that's the better result. But what happened when you just do your follow-up after 1 year, and sometimes the patient don't get properly take care of themselves, and you can see it swelling again. I don't know if it happened to you. I just say in my experience that the patient don't use the garments and forget to go back to the. And what happened with those patients that you perform liposuction? How you can see if happened to you, if you can see it, the tissue change or get swelling again or get fibrosis. Do you have some cases like this?
I showed you the 65 cases we were looking after these 15 years now. We have much more cases which are not under this control. And we like to see them years afterwards as well. I'm interested when you say you are doing a patient with 2 legs, and the one leg with sonic ultrasound and the other not, and you don't see any difference after a year, so you can quit the ultrasonic. That's the easiest thing. Don't use it. But immediately to your question, if you have a new lymphedema, this would be the idea. Coming again, I do not believe this really. Then I would always say, do again the suction if you are suction guy, And if it doesn't work, I send them to John to Vienna and say, now it's your turn. Bring better results with doing the LVA. Why this way? When I do the suction first, I strictly go along to the lines of the vessels. I know where they have to be anatomically. So I will not do anything. I will not treat them. When the patients first go through the LVA, then we have a other way of anatomic situation in there. And I would like not to damage these. So I think it's better first take away the stuff in the deep. And then if it's not enough, is what you told us, then the second way could be the combination with one of these possible treatments via LVA or others. But there's no protocol. Again, we need to do this. Thank you for your questions. And good luck in your job and creating the Center for Surgery and Lymphology.
Yeah, actually.
I really appreciate it.
So
Thanks a lot.
Thank you so much, Alejandro. Yes, actually, it's not so much centers of lymphedema in Latin America. Actually, I only aware of two, like from Dr. Zapata in Colombia and Dr. Pereira in Chile. So this is really important. And next, I hope so in Peru too. So next ambassador, APS ambassador will be Mario Cherubino from Cleveland Clinic Abu Dhabi. Dr. Cherubino, do you have any comment or question to Dr. Corneli or any other panelists?
First of all, I have to do my congratulations to everybody for their very interesting topics and for the presentation of Professor Corneli. Thank you very much, sir, definitely. I think that we already have a lot of discussion about all the different aspects, but the key stone that come out in our discussion, it's about when it's a good indication to do the lymphedema and the liposuction treatment. Because as you said immediately in your presentation, we have different tools that can be combined them nowadays, LVA together with liposuction, etc. However, to have the best long-lasting results, it's when we have to use them. Because if you have only once in your hand, you always use that solution. But if you have all the different tools we have, and plastic surgery is interesting because we do so many different combination techniques, and we have to find and to be focused on the indication. So to standardize and to see a good indication of your patient and say, okay, let's do the liposuction first, and then trying to do the LVA, or vice versa, do the LVA and then the liposuction. Do you have any imaging or any idea or anything that can be helpful for who is starting in this world to say, okay, maybe we should do MRI study with lymphatic vessels, or no, that's a stage one. I'm sure that the liposuction will be the good indication to have the best results. So what are the imaging that you will suggest for someone who is starting?
So thank you for your question. We don't use any imaging in this moment. We use it when we prepare it for the LDA. Then we go to have an MRL, lymph angiography with the MR. Typically. And I know
but you don't do first.
But we never do it before. It's not necessary because the vessels itself are not damaged in secondary lymphedema. They are damaged in primary lymphedema. That's another question. When we do the same treatment in primary lymphedema, I always before have the imaging of the vessels because I want to know where's the problem, a deep or superficial problem, so that we can take the cannula in another way. So, second question, second type of part of the question. I think in this moment, the anamnesis is clear and the secondary lymphedema is clear, clinical clear. You can see it, you can feel it, you can touch it. Then you can first try to go on with conservative treatment. Take, I don't know, half a year, consequently, When you see it's working and it's working good, then reduce the conservative treatment. The aim has always to be, even if you're just conservative treating, less is better than more. So try to reduce it after half a year. And when you then see you have no chance, then take the second tools on the table, which are the surgical tools. And then you have to decide which one would you take. And my opinion is easy way, first section, and afterwards anything in the vessels. But this protocol is not closed. It's my idea. Maybe we find here another idea, and other guys as you and John and Alejandro may say, no, we first would like to do the LVA, and then we have good results. Then my question will always be, could you reduce the size and could you reduce the necessity for the conservative treatment? These are my 2 points I want to know. And if you manage it this way, then it was good. So again, what we need is an international protocol from the colleagues doing these jobs to say, how do we measure? What do we want to know? What is our idea? And then have a group from, I don't know, 10 colleagues doing this all over the world, the same protocol. And then we meet again and say, best result would be in this year. I tell you another way around. Tomorrow, you will see a new patient coming to your office, 50 years old, secondary lymphedema after breast cancer. And she will say, Mario, you are the specialist in this question. What would you say for me? She is a girlfriend from your wife. She will ask you, give me your best solution. And then you know there are a few solutions, and you take the one you're always cooking with. Yeah, but you do not know if it's the best. That's one of the problems.
Exactly.
So in my office, only these sections, because we do not do anything else. And I cannot give you the answer to say, okay, in this special patient, it would be better to have first the LVA and afterwards a suction, because we have no experience in this. And that's, again, we need this protocol.
I do agree with you completely in whatever you said. Thank you very much. And also, if you think about, there is always this problem about the new technology coming out, and you never know how much it's the industry that say it's working, and everybody say, oh my God, I have to change my practice because without that industrial thing, it's not working anymore. So I think that we really need to find a protocol way to treat the patient and find the good indication and use the different tools in the right moment for that one. And that's absolutely.
Yes. And just small comment on these. Industry wants to make money.
Of course.
It's not the job of industry to heal patients. That's not their job. They want the money. It's okay. They should earn money. But what we want as doctors is to help the patients. And this is what I told you. I think the first has to be, which is the aim we want to reach. And when we know this aim, and when we know enough on lymphology, yeah, for example, the skin fold thickness, I think it's unbelievable. That is 17%, 70% of the volume. You're doing your suctions and you're doing your LVA, and you say, why is this arm still so thick? Just because of this, of the skin. Yeah. So necessary to know this. These are things interesting. And maybe there will be an industry bringing us a device to smoothen the skin. Maybe, I don't know at the moment, I do not really believe, but it doesn't matter. First of all, again, aim and scope, we could tell it, and then you're clear in your decision, and then you go with the protocol.
Absolutely.
I would do it this way.
Thank you very much, Professor.
You're welcome.
Thank you.
Sometimes the industry make you fancy, but not effective. You know, it's different.
That's true. So I want to share my experience here in Asa. I've been here like 2 months, and I've been seeing a lot of lymphedema. Actually, the first weeks mostly secondary lymphedema, and these past 2 weeks primary lymphedema that I think is really hard to treat. Some Noonan syndrome, Turner syndrome, really hard to treat. And actually, the last conference that I went was in ASRM. Dr. Nelligan was having a discussion with others, like about how low is the content of literature about lymphedema? Like, it's like you can group like 10 authors that talk about lymphedema, that have like protocols about lymphedema. Same goal, different treatments, similar maybe. So to answer Dr. Cherubino questions, when I do an LPA, when I do liposuction, when I do that, the protocol here in Assam is first stage, mostly they do bandage, and then rehabilitation exercise, and then second, third stage LB8, lymph node anastomosis too, and third stage mostly is excision and liposuction. And if they maybe did not find a good size of the lymphatic, like 0.2, lower than that, they do liposuction. So the scar is like really tiny, so they can maybe do LBA later in a second stage of the operation. And about the mental flap, actually this week we have 2 pediatrics patients, and it was really hard to treat them. And we actually started looking for a mental flap in kids, and we couldn't find, maybe only 2 articles. And one of them was using Omental for neurosurgical procedures only. I mean, in kids for 9 years old. So it's not like a lot of literature that you can take, and this is the evidence, so I'm going to do this because I have this. It's no evidence. It's not that much literature. So it's really hard to, like Dr. Nelligan say, like I group all the literature. I know what is right, what is not, because things function differently, because you do what you think, what is work for you. I mean, you already have a lot of evidence, like 15 years of evidence, that you can say this work, and I do it this way, and this is working. So Japan, Taiwan, Korea, and now your country, Germany, have a lot of protocols, and it's working. So I think these kind of publications is really important for other surgeons in other countries, so we can replicate and aggregate treatments and look for best options for the patients. So thank you so much. Do you want to make a final comment, maybe?
Yeah, I want just one last comment. You know, sometimes in lymphedema, lipedema, or all stuff, you cannot find, meta-analysis, but the experience of the surgeons still be evidence. You see, even if you don't have a properly comparison, random comparison, and all those stuff, even if you don't have it, you have the surgeon experience, and it still be great tool. You need to follow up. You need to do like you are doing, going to find your answers all around the world, because sometimes you're gonna find good answer and will be your protocol. You see, so that's for me. It's a great opportunity to know how handle Professor Manuel, how do it. For me, it's a great evidence, even if you don't have like meta-analysis. For me, it's a great opportunity to learn, and every single opportunity of these panelists will be great evidence for my patient, because it's all we have now. Maybe in the future will be different, but now it's all what we have, and it still be great.
Exactly. About fibrosis. Tomorrow I go in, like, first thing that I'm going to do in the meeting is tell Dr. Pak, Dr. Sa about the hyaluronidase. It's going to be, this doctor is published these long-term cases, and I think we make him try hyaluronidase in our liposuction solution. So let's see what they say. Actually, they use Baser here, Dr. Corneli, and liposuction. They work really good. And one of the international visitors in Spain, he said that one of his attendings is using in lipedema Baser and Renuvion, and it's worked really well. So, like Alejandro say, I mean, experience, even if you don't have like meta-analysis or anything, experience work. I mean, it's really important, and it's important to you to see everything. You can take this to your home and make your own protocol. like, this is working, or say, I can combine these procedures, I can do this, I can do this, and work with the thing that you have, actually, because we're talking about third world countries. Sometimes we cannot apply the same protocol that maybe in a first world country. So you have to work with what you have. So this is really important. Dr.
Just
Yes.
allow me a last comment from me to your comments, how you do it in your clinic. You said that in stage 1 they do compression, they do conservative treatment. In stage 2 you do LVA, and stage 3 do liposuction and nodules or something like this.
Excision.
Why? Yeah, terrible. No, liposuction. Why do they wait a stage 1 becoming a stage 2 to do the surgical treatment? There's no sense. You can treat it in stage 1, surgical way.
Oh yeah.
For example,
I
I told today, and then have a follow-up and see if this stage 1 patient, which is small, thin skin, becomes ever a stage 2 or 3. I believe you will stop the progression when you do it early.
Yeah.
So it doesn't make sense to wait, but it might be the protocol of the clinic. And so the next question has to be, why is it this protocol?
No, I'm sorry, I didn't mean to say that. I mean, they do first thing that they do is always LBA. They do lymphositography first, always LBA, but the first treatment, I mean to say, I'm sorry, is always like bandage and rehabilitation. So it's first day 1. Since day 1, they do bandage and compression. That's the first thing that they do, because more you compress, more is the flow is going to help the lymphatic.
Sure.
That's the first. I'm sorry.
This was what I told with the question how I would do it. If there's a new lady with a new lymphedema, I would always start with the conservative treatment for 6 months.
Yes.
And then begin to reduce this treatment. And if I have no positive effects in reducing, if I need to go on, then I would give her surgical treatment.
Exactly.
Immediately, just because I do not want it to become a stage 3. I would like to stop it as early, as quick as possible. And now we would have to discuss, even to the time we will not do, which would be the best way. And then we are again with the protocol, is it suction or not? I believe suction before and afterwards the LVA, because of the easy doing suction and the more complicated LVA.
Exactly. One more question I forgot to ask. What is the first complementary exams that you send for diagnosis of lymphedema in these patients?
Complementary?
Yeah, like lymphocytography, MRI.
Sorry. No, I'm sorry. I'm a dermatologist. We do anything with our fingers and we are looking. A lymphedema to diagnose a lymphedema is quite easy. You have a positive anamnesis, surely. You can measure the leg, or the arm, and the necessary is you take this fold on the finger. This is Kaposi sign positive. Yes. That's enough. Then you know there's a fibrosis in there, and a fibrosis of the skin of the toes or the fingers is only be found by lymphedema. No other edema makes a fibrosis in there. That's typical. If you have there a fibrosis, then it is a lymphedema. You do not know why there's a lymphedema, but then it's a lymphedema. And then you have to call it a lymphedema and you treat it as a lymphedema.
Yeah. So that's
I just need the imagings for the question for preparing, for example, primary lymphedema. I want to know, even in this patient, we do the genetics necessary to know which kind of primary lymphedema. Well done jobs by Mortimer and by Hagerling and other guys. This all is published by Gordon. And in secondary lymphedema, I want to know if it's how the condition of the lymphs when we bring it to the surgeon who does the LVA, to John Zhu in this case. That's it. There is, I think, more imaging you do not really need. You can do image whatever you like, but I think you do not really need it. Always aiming scopes.
Yes. So the first exam that they send here is lymphoscytography. They do that for every patient, that you can see the dermal pattern of the lymphatics. So
Yeah.
you can pronounce like what kind of
Yes.
issue the patient have. Then they do the MRI with ICG, then ICG in outpatient clinic to see the pattern.
True.
That actually is very correlated with the lymphoscytography.
Yeah.
And the ultrasound. One day before, always ultrasound to see the quality of the lymphatic, the size of the lymphatic, and they map, so it's easier to find. Actually, LVA bypass or boosting is really fast here. You can do like 3 or 4 per day, because the planification is really, really good. And planification sometimes last week we have so many cases, and we start Sunday at 2 p.m. we finish like 2 a.m. because we have to map all the patients. And I can certainly say that primary lymphedema is really hard. The vessels in this, the mechanisms of the lymphedema is hypoplastic or even aplasia of the lymphatics. So it's almost impossible to do it, but Dr. JP does.
If you have a good ultrasonic machine and the situation in the clinic where you're working, I would do it the same way, because anything we can bring with new information in the science of lymphology, we are talking on a new science. It's a terra incognita. Nobody did it before, so we can do anything. But we have to decide which makes sense and which doesn't make sense. But if you can do some ultrasonics and have good mapping, for example, that's good. Just to the scintigraphy, when you see, clearly clinical signs of lymphedema, which means thicker skin, then you know that the dynamic of the lymph scintigraphy will be worse. So you can do it, but it's just for control your clinical signs, or why do we do this?
But I think is different approach. You see, for example, the approach from the doctor is more like clinic, because he is based in his goals. You see, his goals at the beginning of his talk is like, we're gonna find if we can help this lady or not. You see, so he based everything about clinical exam. Sometimes I heard Jaume Masia talking about lymphedema is more like my grandma eye. You see, if for my grandma I have lymphedema, so I have lymphedema. Okay, so you don't need like lymphoscintigraphy, MRI. Actually, I perform MRI and lymphoscintigraphy because I am a huge fan of MRI, because with MRI you can measure everything. But I know what was your approach, and it's very interesting. And for me, I also find some investigation from Hiroswamy in Australia, and he used to say, like, when you perform liposuction, it's like your lymphatic system become like, like chalk, like huge discharge of energy, and they find the way to make new connection. I don't know if you have the opportunity to know about his work, but he performed LBAs, and also he performed liposuction, and then he mapping all his job in every single extremity, and he find that sometimes the lymphatic system find new ways, you see, and use different. And I know your goals, and just for the record, the best garments in the world coming from Germany, because it's no competition at all in the market. I use it, I love it, but the thing is, a different approach. And Dr. Cornell, I believe that you have many questions resolved today for me, and I really appreciate it. And it's different approach, I think, Rocio. It's like he's more like clinic evaluation, and if he can see if he can help the lady, so he goes straight, and he has his protocol. And 15 years is outstanding.
Yes, a lot of time. Yes, definitely.
Thank you very much. And again, I just want to point out the problem again. Remember, every 20% of all the breast cancer patients will have a secondary lymphedema after around about 2.5 years, 20%. And they have to be treated the best we can do. And the best we can do is to bring the secondary lymphedema away. And we can do this by surgery. And we can never do this by conservative treatment. We'll never see this in conservative. Thank you very much.
Thank you very much. So thank you so much for your support to the APS, and see you next time, Hot Off the Press. Thank you so much for ambassadors, Dr. Corneli.
Thank you, Professor. Thank you, Rocio.
Now
Thank you all.
Thank you very
Thank you,
much.
Mario. Thank you, John.
Thank you everyone for joining us this fantastic discussion. Be sure to tune in for the other article that we'll be discussing on this month's Hot Off the Press. You can also connect to Global Plastic Surgery Society through our YouTube channel, Facebook, Instagram, and Twitter. We're looking forward to meeting with you on our APS social media. See you soon.